So let's go ahead and get started. Welcome today to High Rounds. We have a very special guest today. As you can see by the title, we're going to be switching gears a little bit and talking about families and HIV. Today we have Dr. Michelle Ann Bulterys, who is an epidemiologist specializing in maternal, paternal, and child health among families affected by HIV in Sub-Saharan Africa. She trained in anthropology and global health at UCSD and received her MPH, PhD, and postdoctoral training in epidemiology at the University of Washington. Dr. Bulterys' research is primarily based in Kenya, Botswana, and Uganda, and focuses on caregiver relationships and mental health, father engagement interventions, and child neurodevelopment. Dr. Bulterys currently serves as a scientific committee member on the UNAIDS WHO Pediatric Reference Working Group in International Maternal Pediatric Adolescent AIDS Clinical Trials, or IMPACT Network Scientific Committee for Brain and Mental Health, and as the Research Methodology Advisor for the NIH Fogarty Global Health Program for Fellows and Scholars, known as LAUNCH program. Dr. Bulterys attended elementary and middle school in Zambia, high school in China, and has lived and worked in Switzerland and the United States. So she comes to us with an extensive, diverse background, and we're happy to have her today talk about interdisciplinary research journey from pediatric HIV in Sub-Saharan Africa to father engagement. So Michelle, go ahead and take it away.
All right. Thank you so much, Dr. Lee, for that introduction. And thank you all so much for being here today and for welcoming me to speak about my work. So my name is Michelle Bulterys, and I'm really grateful for the opportunity today to talk about family dynamics within the context of HIV, and mostly within the context of Sub-Saharan Africa today. Before I get started, I just wanted to quickly mention that the photos in this presentation are photos I've taken myself or with our team with parental and child consent. They are not intended to depict or imply HIV status or health status otherwise of any of the subjects. And the photographs are merely included to serve as a reminder that there are very colorful and vibrant lives behind the numbers in our data sets. All right, so I think this slide actually covers most of what Dr. Lee explained already, but I'm in my 5th month as an assistant professor now at the UC San Diego School of Public Health. It's an honor to be back. I came here for undergrad to study anthropology and global health. And actually, my undergraduate mentor, Dr. Richard Garfien, is on the call today. And over the last decade, he's continued to mentor me in many ways, even as I went on to other exciting opportunities and studied in the University of Washington to study epidemiology. And UCSD was always the place where I called home, where I wanted to be my forever home. So I'm really, really excited to be back. And my research is mixed methods. So today I'm going to be using I'm going to be giving some examples of qualitative and quantitative research, some mixed, some individual, as their own methods. And I encourage you to ask questions, and you're welcome to ask questions through the chat box at any time. I'm very lucky to partner closely with researchers at UCSD, University of Washington, Harvard, and I also work closely with UNAIDS and UNICEF. In between my undergraduate studies and my master's, I actually was fortunate to live in Switzerland and work at UNAIDS, so I get to continue working with them each year. I love soccer, I love photography, and I love tacos, so I think it's a perfect time to come back to San Diego. So today I will share some highlights from my research journey over the last few years. My research focuses on how HIV impacts relationships, and then also how HIV and relationships together can influence child outcomes, and how we are working with communities to design interventions to best support families affected by HIV. And as you'll see through my talk, that has actually continually pointed to the need for engaging fathers. And I thought it was only fitting to start my talk, which is about families, by introducing you to my family. So I'm a child of immigrants from Belgium and Taiwan who both happen to be epidemiologists. I've been immensely fortunate to have these role models in my parents as well as my older brother who have all dedicated their lives to the service of others through global health research, through medicine. And thanks to their work, I grew up in Zambia, where my parents helped lead the first implementation of PEPFAR in the country. And shadowing them at clinics and learning about obscure diseases on a daily basis, much to the development of my own hypochondria, I did find this work to be incredibly stimulating and fulfilling. And growing up, many of my closest childhood friends were either living with HIV or had been orphaned by HIV, as Zambia had one of the highest HIV prevalences in the world at that time. And witnessing the physical and emotional adversity that my friends faced inspired me and instilled a lifelong passion for studying HIV in families. So my research covers a wide breadth of HIV topics across the life cycle, and here's a quick snapshot of some of the recent projects that I've been involved in. They are related to HIV testing and prevention. They are related to child development, and then on the far right, most recently, father engagement. So today I'll be taking a deeper dive into a few of the studies and interventions that have been formative in paving my research path, and you'll see how the progression of the work has led to the next thing. And so today I'll start by talking about families and relationships. I'll move on to talking about child neurodevelopment within the context of HIV exposure in utero. And then I'll end by talking about community-driven interventions to engage fathers. And I'm going to start by describing some context and background throughout, which is informed by projects that I've worked on with UNAIDS and UNICEF partners, including evaluating the global vertical transmission rate of HIV from mothers to children, and with UNICEF looking at the population changes over time of children who are HIV exposed uninfected. All right, so let's start our journey by talking about maternal HIV and treatment. So high birth rates and high antenatal care attendance in Sub-Saharan Africa means that antenatal care clinics are actually a very promising entry point for finding women living with HIV to receive their HIV testing and treatment to prevent vertical transmission. And antiretroviral therapy, or ART, can greatly reduce the risk of vertical transmission. So here's a quick figure I pulled together using UNAIDS data to show the changes of ART regimens over time. So on the left, top left, if we look at the blue depicts the proportion of pregnant women living with HIV who are not on any treatment. And as you can see over time, different treatment regimens were introduced. And now the majority of women living with HIV are actually on treatment before they even get pregnant. But how do we track the impact of these treatment improvements on vertical transmission rate over time? So that's what we were asked to do this year. Actually, sorry, the end of last year, I was invited by Dr. Jeff Imai Eaton from the Harvard Department of Epidemiology and Dr. Mary Mahey, the UNAIDS Director for Data Impact, to co-lead a systematic review and meta-analysis to update UNAIDS's model estimates of global vertical transmission in this new era of ART regimens. So UNAIDS has conducted multiple past reviews, 3 actually, one in 2012 in yellow, one in 2015 in orange, and one in 2019 in red, because UNAIDS wants to rely on published data in order to inform the model estimates. But this has not been updated in the last 6 years, which means that the UNAIDS models are not capturing the most up-to-date latest regimens out there for treating pregnant women living with HIV. So we screened almost 7,000 papers from the last 5-6 years. We had 400 full text articles that we reviewed, and we extracted data from 24 relevant studies. And we also pooled data from all of these final studies. So across all 4 reviews, we had a meta-analysis of 111 studies to look at. The reason we included past reviews in our meta-analysis was to show the progression, to actually be able to show in the last 2-3 decades how the changes are coming out in vertical transmission rates. And these were the key updates that we made to the UNAIDS models. So we found that the risk of vertical HIV transmission ranged from less than 1% to 18%, depending on the geographic location, depending on maternal ART regimen, and the timing of her initiation. So we looked at different segments, so whether she started years before pregnancy, she started right before conception, she started during pregnancy, or right out at the time of delivery. And then we found significantly lower risk of perinatal transmission, so about 10% lower risk, and also a higher risk of breastfeeding transmission, so 6.4%, compared to UNAIDS's default values from 6 years ago. So in the last 6 years, to just reiterate that, we found a lower risk of perinatal transmission with our updated estimates, but we found a higher risk of breastfeeding transmission. One of the reasons we think that is because there is longer follow-up time now than there was before. Women on dolutegravir had 79% lower odds of transmitting HIV to their children compared to women on efavirenz. I want to note here that please take this with caution. Unfortunately, there were only 5 relevant studies that we could look at. All 5 did show this difference. However, because it's such a small sample size and because dolutegravir has not been published on enough for us to make conclusive to not make conclusions about this, just take it with a grain of salt. But there is a trend in the right direction here. And actually, just last night, our paper was published in the Lancet HIV, if anyone is interested in reading more about it. All right, so now how does maternal HIV infection impact family and relationship dynamics? So during my PhD, I worked on the Obumu study led by Dr. Connie Kellum and Dr. Andrew Mujugira in Uganda. We tested a variety of interventions to reach male partners of pregnant women living with HIV, to encourage male partners to test for HIV and link to prevention or treatment depending on their results. Working on this study for all 5 years was very eye-opening, and I was fortunate to spend an entire summer during my PhD working at our Obumu clinic and realized that several of our couples were separating. So I decided to focus a big part of my dissertation on identifying factors associated with relationship dissolution or separation using mixed methods. So just a quick background on relationship dissolution in families affected by HIV. We find that couples affected by HIV face disproportionately high risk of separation, especially if the female is the one living with HIV compared to if the male is the one living with HIV in serodifferent couples. We also see that women living with HIV are especially vulnerable to intimate partner violence. Separation is theorized to impact their mental health, engagement in PMTCT programs. And I also just want to point out here in green that in Uganda, polygamous unions are legal and a socially acceptable practice. It's estimated that 9% of marriages nationally are polygamous. And I'm bringing that up because I'm going to come back to that in a bit. So I'm a mixed methodologist, and this picture from the movie Rocket Man represents how I sometimes feel about integrating social interaction, qualitative research, anthropologic research with standardized questions from the quantitative side of me. But I believe that we can tell a much more complete and rich story and ensure that our quantitative data are rooted in real lived experiences by including qualitative data. So I really love this quote by Dr. William Fagey, which states that public health is at its best when we see and help others see the faces behind the numbers. So that's always been my goal. So we tested the association between exposures, which were relationship factors, and the main outcome, which was separation, any time in the study period, which was from pregnancy to 12 months postpartum. And additionally, we wanted to see if there was an association between separation and maternal HIV treatment outcomes, such as viral suppression or ART adherence. And we used both quantitative and qualitative methods to look at these factors. So in Obumu, we had 500 couples, and all of the women were living with HIV, and not all of the male partners were. So 23% of our couples separated within the study period. And 43% of those couples that separated were polygamous, compared to the 25%, I think I made a mistake here. I believe it should be compared to the 9% of couples that are polygamous nationally. We also asked men if what they thought their female partner's HIV status was, because many of the men actually didn't know that she was living with HIV. So we saw that 58% of men knew that she was living with HIV, 15% thought she was HIV negative, and 27% said that they did not know his male partner's status. Quantitatively, we found that being in a polygamous relationship, being unmarried, not living together, being together less than 1 year, these were all significantly associated with separating within 1 year of postpartum. And additionally, we saw that multiple measures of relationship dissatisfaction at baseline were also significantly associated with separating. Qualitatively, we saw that women feared that HIV status disclosure and serodifference would inevitably lead to abandonment or abuse. And serodifference, if for anyone who is unfamiliar, means that they are in a relationship where one person has HIV and the other person does not. Oops, sorry. So in mixed methods research, there are three key ways that we like to compare quantitative and qualitative data. So there's contradiction when our quantitative and qualitative findings disagree with each other. And that's actually my favorite because that's where I feel like we learn the most. Concordance is when we have total agreement between our quantitative and our qualitative findings. And then we have expansion, where either our quantitative or our qualitative shapes our entire understanding of the other. And so I'm now going to show three examples of our findings that correspond with contradiction, concordance, or expansion. So first, an example of contradiction, or it may seem like contradiction at surface value, sorry. So our qualitative data consistently suggested that if a woman disclosed her HIV status to her male partner, it would inevitably lead to abandonment. So this interviewer says, "Why did you not want him to know your HIV status?" And she says, "I knew he was going to leave me." However, this actually contradicted with our quantitative data, which found that not disclosing HIV status was associated with a 3 times higher risk of separation. And at first we were grappling with this contradiction. And then after a lot of conversation with our study team, we realized that this could likely mean that the women who chose not to disclose did so because their partnerships were the most fragile. So an example of concordance or agreement, we found that men's fear of contracting HIV from his male partner was higher among men who later ended up separating with their partners than among the men who stayed with their partners. And qualitatively, we also saw this gentleman says, "My wife told me that if she adheres well to her drugs, then she can't infect me. I didn't believe what she told me. I said, if HIV is death, then you have surely killed me." So men are fearing contracting HIV. They're also bringing in blame and accusations into the relationship, which unfortunately did lead to more separation. We also saw that men and women acknowledged that HIV was not the only factor leading to their separation, but it merely exacerbated existing problems in their relationship, like financial burdens and gender expectations. There were very clear gender roles, and then those unmet expectations led to other frustrations and blaming within the relationship. So here's an example of expansion. We saw that having children quantitatively was associated with a 15% reduced risk of separating. But then qualitatively, we actually see a much deeper story. This gentleman says, "We are together now, I think because of the children. I pray that one day she sees me as someone who is worthless, someone with no good future, so that she leaves me. But when I think about the children, I keep lying to her that I will stay with her, but I really do not know. You never know, but since I have produced children with her, dot, dot, dot." And this gentleman had a lot of conflict, internal conflict. And actually, we saw this among a lot of the fathers in our study. So this is an example of mixed methods expansion, because if we had just seen just the quantitative finding, we would have gone a very different route with our interpretation. Then now with mixed methods, we have a much fuller story. So it's not just that children are protective, but actually there's a lot more under the surface. So this begs the question, is separation always a negative outcome? Because that always is how it sort of comes off when discussing separation. And we did see that separation was associated with a decline in physical and mental health outcomes, poor PMTCT outcomes, and financial hardship, among other outcomes. But we also saw many positive outcomes of separation as well. For some women, separating offered an opportunity to now invest in their self-growth, improve their physical and mental well-being, lean on their own social support systems, and for some women, it was an opportunity to escape abusive relationships. And you might be wondering about what about the other three-fourths of the couples that stayed together? So when we examined those couples, we saw palpable love and support. Women wanted to disclose their HIV status the second they were tested because they did not want to keep secrets from their partner, and they wanted their partner to test immediately so that he could prevent or treat HIV depending on his results. These couples exhibited teamwork, and we actually saw a dissolution, almost a disappearance of stereotypical gender roles within these couples, which seemed to plague the couples that separated. These couples, we also saw that men felt protected from HIV, which served as an important predictor for staying together. And their protection could have been from God, could have been from the fact that they had been having unprotected sex with their female partner for many, many years and never acquired HIV, which meant that indeed U equals U, undetectable equals untransmittable, was something that they could count on. All right, so I know we breezed through that very quickly, but I just want to show that in mixed methods, in order to organize and present our results, it's important to develop joint displays that convey quantitative data backed by illustrative quotes. So this is just an example of a joint display from my dissertation. In the red wheel on the left, I present the factors associated with separation. In the blue-green wheel on the right, I present factors associated with staying together. And as I move inwards, I provide quotes as illustrative evidence. And then the dark pizza slices within indicate statistical significance, that those factors were also statistically significantly associated with separation or staying together. And the light gray slices indicate concepts that I was only able to identify using qualitative methods. So just an example of what a joint display can look like. So in conclusion from this work, we found that relationship instability and separation are frequent among couples affected by HIV. Separation could affect father engagement, maternal HIV outcomes, mental health, and financial security. And interventions are urgently needed to support couples affected by HIV. Okay, so now halfway through my dissertation, I had to ask, what about the children who are born into these families who are affected by HIV? So I started to learn about child development. And thanks to the massive success of HIV programs over the last 2 decades, we now have a rapidly growing population of children who are not HIV infected, but who are HIV exposed uninfected. So I'm going to refer to them as CHEU today. And for the last 5 years, I've worked annually with UNAIDS and UNICEF to track the global growth and geographic clustering of these young populations of CHEU worldwide. We now estimate that this population has 16 million children, and about 1 million more are born every year in Sub-Saharan Africa. In several Sub-Saharan African countries, the prevalence of children under 15 who are HIV exposed uninfected actually can exceed 20%, sometimes as high as 30% in places like Eswatini. This means that in certain settings with very high HIV burden, like South Africa, Botswana, Eswatini, over a quarter of all children are born HIV exposed uninfected still at this point. And this has massive implications for an entire generation. Despite living HIV-free, despite being born HIV-free, CHEUs still face higher risk of mortality, hospitalizations, and poor development. So a close colleague and friend of mine, Dr. Catherine Wedderburn at the University of Cape Town, conducted an excellent systematic review and meta-analysis of 31 studies comparing neurodevelopmental outcomes between children who are HIV exposed uninfected and children who are not HIV exposed. And most of the studies, not all, there was some variability, but most of the studies found that CHEU had significantly poorer neurodevelopment outcomes compared to their HIV unexposed peers. And while there was some heterogeneity in the findings, this still begs the question of what is driving this difference if they are not acquiring HIV. So Dr. Wedderburn and I came together, along with our colleagues from UNICEF and UNAIDS, to take a deep dive into the literature and understand all the possible mechanistic pathways through which HIV exposure in utero could impact their neurodevelopment. So we found that perinatal exposure to HIV virus, ART drugs, and other biological phenomenon do indeed contribute to altered infant immunity, brain maturation, adverse birth outcomes, and growth faltering, all of which we know can negatively impact a child's neurodevelopment. But the biological factors are only part of the story. And when we think about nature versus nurture, we have to pay attention to the social behavioral mechanistic pathways as well. So we know that there are social inequities associated with growing up in a household affected by HIV in Sub-Saharan Africa, such as caregiver distress, HIV stigma, violence in the household, and food insecurity. Based on all the current state of literature that we looked at, we found that the biological factors are much better understood than the social behavioral ones, on which very little data exists. But these factors are likely more approachable and readily modifiable through interventions. And since the time of about end of my PhD into my postdoc and still to this day, I'm trying to fill these knowledge gaps within the Kenyan HOPE study. So the HOPE study is a multi-site prospective longitudinal cohort involving 1,000 mothers living with HIV and their children who are HIV exposed uninfected, and 1,000 mothers not living with HIV and their children who are not HIV exposed. We have followed these mother-infant pairs every 6 months since birth, and the HOPE children are actually now 3 years old. I'm particularly interested in understanding the roles of maternal HIV, relationship dynamics, and father engagement in their outcomes. So just at baseline and, just looking at very simplistic regression models, we found that CHEU in our cohort compared to CHUU were significantly more likely to have older mothers and older fathers, parents with lower levels of education, higher rates of food insecurity, less likely to have father support, and multiple measures of worse relationship stability and satisfaction between mother and father. So all of these are known risk factors for poorer child development that are all magnified among families affected by HIV in Kenya. So we assess neurodevelopment using the Malawi Developmental Assessment Tool, which is a culturally validated tool developed in Sub-Saharan Africa for use in Sub-Saharan Africa, and it measures social, language, fine motor, and gross motor domains. The colorful cells here indicate statistically significant associations, and the blank cells represent no statistically significant associations, and I did that just to spare everyone's eyes. And we found that at 2 years of age, CHEU had significantly worse gross motor development compared to CHUU, compared to children who did not have HIV exposure. And this was primarily in terms of the ability to walk and run. In a sub-analysis, so that row number 2, we found that this was likely attributable to CHEU whose mothers were on efavirenz-based regimens during pregnancy and postpartum. And because the children who were HIV exposed uninfected, who were exposed to dolutegravir regimens during pregnancy and postpartum, performed just as well as the children without HIV exposure at all. So we believe that it was the children with the efavirenz exposure that drove that down. We also saw there on the bottom row that among all children, regardless of HIV exposure status, children who were assigned male at birth performed significantly worse developmentally in almost all of the domains. Anyone who works in child neurodevelopment research studies knows that this is not a unique finding, and has actually been a consistent finding across all of our colleagues' studies. We saw a positive trend where the longer parents were together, the better children performed in the language and fine motor domains. We also saw that relationship satisfaction measures played a role. So lower scores were found among children whose mothers considered separation more than half of the time, or if parents did not confide in each other, or if parents did not engage in shared interests. And lastly, we also saw poorer social scores among children whose fathers did not live with them, or who had infrequent contact with the child. We had several measures of father engagement, but father engagement was actually unfortunately so low in this population that we had limited power to detect any differences in child development domains. But it's something we want to explore further. So I decided to apply for a small grant, an administrative supplement grant with our HOPE study to conduct a photo voice study with fathers. I really wanted to elevate their voices. I really wanted to understand their challenges, their needs, and their priorities when it came to parenting. And in this, actually, maybe I'll mention really quickly for anyone unfamiliar with photo voice, it's a qualitative research method whereby we give cameras to participants to visually narrate their lived experience. So we give them prompts and we ask to take photos of their biggest challenges as a father, their biggest priorities as a father, and so on. And they can take photos of anything and come back to us. So I'm just going to have a few slides here where I describe some of our photos that we've gathered over the last few months. So we found that fathers' biggest challenges were often rooted in financial instability. So here on the left, we have a father carrying a sack of tools looking for work. He says, even if you manage to get some money, the stress from the environment and the pressure from home can be very difficult to handle. It affects you deeply. Next, in the middle, we have a father who was locked out for being unable to pay his rent. He says, we men face challenges with having low income. When an issue arises that requires us to support the family and we lack the means to do so, it becomes a major challenge. And then on the right, we have a photo of a father teaching his son, his very, very young son, the importance of money from a young age. We also saw that caregivers described that fathers hold much greater value than just providing financial support. This father on the left says, this is a photo of me walking to the shop with my sons. We have a very close bond because I am often at home more than their mother. Being a father for me means being close with my children so that I can understand them, understand their needs, and be able to bring them up in the best way possible. On the right, this father says, being a good father means that you provide support for your family, whether it's moral support, mental support, or any other type of support. As a father, you are there for your family in various ways. I just really like these two photographs. The fathers here were explaining why their parenting priorities are focused on education and faith. They want their child to have the best chance at thriving. So they want to make sure that they can afford school and not just go to school, but go to school with fresh socks and fresh shoes. And then on the right, this father says that reading the Bible each night makes him a better father because it instills values in him that he can then pass along to his children. And actually, I wanted to end here just for this section on this quote, which is actually less about the fatherhood piece and I think more about the photo voice as a mode of communication for fathers. So this father says, I never knew such things like taking photos and reflecting on fatherhood were needed in life, and a place where I can go and express them because it has been hard. I don't have parents, and I am insecure to express those things to someone because of mistrust, the community, and the role of fatherhood. So, what do fathers in our study want support with? Fathers want more meaningful involvement beyond just HIV testing and counseling for men. And in fact, it's actually a deterrent for their involvement throughout pregnancy and postpartum. They want financial support because it's crucial for their household stability and empowering fathers to fulfill their roles effectively. They want healthy partner relationships. They acknowledge that strong marital communication is essential for financial and emotional stability in the family. And they also want emotional and practical paternal guidance. Varied relationships with fathers highlighted the significant impact of either having a good relationship with the father or an absent relationship with the father, and what that means for the child's neurodevelopment, self-reliance, and emotional well-being. So in conclusion from this work, we found that CHEU compared to CHUU did demonstrate gross motor delays. We also saw that relationship satisfaction and father engagement were critical. We saw that caregiver-based interventions could be useful to support families affected by HIV and relationship instability, and that fathers' voices are urgently needed in this conversation. So, what comes next? I became very interested in fathers at this point. Fathers' voices have been neglected in both the child development research space as well as in the global fight against HIV for many, many years. And in two recent reports, both UNAIDS and UNICEF have acknowledged the importance of reaching fathers and elevating their voices to promote healthy father involvement. We know that fathers are important for family health outcomes. Based on the literature, we see that healthy father engagement improves caregiver relationship stability, satisfaction, reduces household violence and food insecurity, improves the mother's physical and mental health and the father's physical and mental health. It includes child survival rates, and even within the context of HIV, father engagement improves chances of HIV-free survival among children. It improves child neurodevelopment, school attendance, and school success, and it can transform gender equity within a community. However, despite all the strong evidence that we have on the importance of father engagement, a systematic review of parenting interventions recently found that over 2/3 of interventions do not include any strategies to include fathers. Less than half of them report any father participation in the intervention implementation, and extremely few, a handful of interventions, even adjust their approach to accommodate fathers. For example, offering fewer sessions in the parenting intervention, taking a more recreational approach, and taking it out of the clinical facility and into a community setting where fathers would feel more comfortable engaging. So in implementation science, this is what we would call a no-do gap. A no-do gap is the gap between what science tells us will improve clinical outcomes and the gap to actually having effective interventions in practice. So on average, it can take 17 years to translate clinical interventions into clinical practice. And it can take 50% of clinical innovations to ever make it into general use. And 80% of medical research dollars do not make a public health impact for various reasons. So we recognize that this was a no-do gap. And so I was grateful to be invited by Pediatrics to write a commentary about this no-do gap called The Untapped Power of Fathers in Families Affected by HIV. And in this, I looked at the literature, I summarized what we know, I summarized the gap, and I summarized some ways that we could possibly fill this gap through father-based interventions. So with implementation science, we have many different approaches for looking at interventions that could improve outcomes. The first option is we could implement proven interventions effectively to maximize their impact and not reinvent the wheel. Second, we could adapt evidence-based interventions to fit different cultural contexts. And third, we could design completely new interventions tailored to specific community needs. And that is where we want to co-create with community members. So I love this picture of these two cavemen who on the right who are saying that they don't need help. They are fine with their square peg wheel, even though someone is offering a perfectly good wheel. So I didn't want to end up in that situation. And actually this led me to Google three or so years ago. I just Googled father interventions in Sub-Saharan Africa that are effective. And the first one that came up was Real Fathers, which is actually based at UC San Diego and conducted in Uganda. So Real Fathers stands for Responsible, Engaged, and Loving Fathers. It is a father-to-father peer mentorship model that has significantly improved child outcomes, father engagement, reduced violence in the household, and improved relationship between mother and father in this community. It is funded by the Lego Foundation, which is based in Denmark, and it uses a 7-phase curriculum talking about fatherhood all the way down to family planning and parenting. This actually was an opportunity for me to engage again with UC San Diego. So immediately I wrote to the PIs, Dr. Rebecca Lundgren and Dr. Kate Barker in the Center for Gender Equity and Health. And I said, can I get involved? I want to learn what you're doing. And I'm so grateful that I just cold emailed them because it led to such an amazing partnership and actually was a big reason why I was able to come to UCSD as faculty. So this intervention I've been fortunate to work on, and actually just last week we saw some testimonials from the families that have gone through the program. And this father says, my kids would always ask their mother where I was. I was never around. Now I spend time with them, talk with them, and play with them. I understand what it means to be close to your children, and this has made our home much happier. So, in addition to scaling up evidence-based interventions, I also want to acknowledge our research partners who welcome workshops and discuss intervention priorities and and allow for study clinic observations to drive the next steps of actually rolling these interventions out into the community. And because we didn't want to reinvent the wheel, we simply wanted to engage with our partners in many different countries in Sub-Saharan Africa to see whether something like Real Fathers could be adapted for their setting. But in addition, I also wanted to be open to new ideas, brand new interventions. So I took an opportunity to embed some questions into one of my mentors' surveys of 3,000 pregnant women in Kenya. And I asked questions about intervention priorities for engaging their male partners. And I was excited to find that 85% of the 3,000 pregnant women said that their male partner would be more likely to engage in a fathering intervention if it was delivered through a sports-based approach. And here's a little, just small clip that we have from our Real Fathers intervention and a quote from our Kenya study. If my child wants to play football, we play together. There is a lot of communication. If he passes the ball between my legs, it makes him very happy. He might say things like, Dad, I passed the ball through your legs. And this interaction brings him joy. So, as an avid soccer player myself, I was very inspired, and I actually have written 2 grants with the international NGO called Grassroots Soccer, which uses soccer to improve health outcomes among adolescents and young adults. And so I'm hoping that I can actually use soccer to engage fathers, appeal to fathers to engage, and then also retain them to deliver a curriculum that's based on father mental health, father parenting readiness, child relationships, and also romantic relationships. And I would like to thank all of our research teams in Uganda, Kenya, and Botswana for their outstanding work that have made all of these research insights possible. And thank you also to our many funders who we're grateful for. And thank you all for the time that you've taken to come to this talk.
Great. Well, thank you very much. That was a very inspiring talk to hear about all your different endeavors, and it's wonderful just to see your passion played out in all of your research. Yeah. So thank you very much. Let me open it up and see if there are any questions. I do see a comment from Paloma. The poor engagement in fatherhood is also a result of how they live their lives as kids. It's like a cycle. And I don't know, Paloma, if you want to unmute or if you want to say anything else, or Michelle, if you want to comment on that, I'll leave that to you.
Well, thank you so much. I almost cry. It's so beautiful, but I was in shock because probably this is kind of similar like in Mexico, like how always like the man has more power and they don't judge them in about having like more partners. But I can see like how difficult it is living over there with all different situations, but no, nothing. I really like it. Thank you. I don't know.
Thank you. Yeah, I mean, a lot of the challenges that we saw the fathers facing are pretty universal. I think a lot of societies experience these challenges wherever it is. And so thank you for sharing that, Paloma.
Great. I think Aaron Wilcox said difficult to interpret inherited trauma as one of the comments.
Mhm.
I see Gigi, you have your hand up. Do you want to unmute?
Yeah, Michelle, outstanding presentation. Thanks so much. I am curious about how your findings, at least on um, the, whether fathers are engaged or not, and the effect on relationships. How does that compare to HIV negative couples where, where they have a more traditional, I guess I'm sorry, I'm not speaking very well. I would assume that the fathers who were not initially engaged with their kids, they weren't unique. I'm guessing that HIV negative families also had similar, more traditional um, uh, types of parental roles. So, can you comment on that? I'm just curious.
And hopefully I understood your question correctly, but from the work that we've done, we've actually really seen that there is no major difference between the families affected by HIV and not affected by HIV when it comes to father engagement. It's just that they do have exacerbated challenges and maybe more fragility in the relationship because of HIV as a factor, whether it's kept as a secret or it's fully, disclosed. But in general, HIV just exacerbated a lot of the existing challenges in the relationship. And, some of the challenges that we saw were very universal. So they've been published on across the world, but things like fathers feeling as though they were obligated to stay with the relationship because she got pregnant before he was ready, or because they had children together, so he didn't want to leave the family. And it would actually ruin his community reputation by leaving a family where he's had children. And so a lot of these challenges are universal, I think, regardless of the HIV. And so actually, Real Fathers, the intervention in Uganda where we're working funded by Lego, that intervention never brings up HIV at all. And actually, when I joined the group as an HIV researcher, I asked, can we test for HIV? Can we understand how HIV is impacting men's engagement? Can we see whether, um, the families affected by HIV are seeing the same results? And actually, it was a total deterrent. So people were worried that if we bring HIV into the conversation, fathers are not going to want to be engaged in the intervention because it might lead to stigma in the community for why they particularly are engaged. Maybe they're in a family affected by HIV. So I think that taking a more broad approach and reaching fathers regardless of HIV in the family is the best way for us to go at this point. And one thing I forgot to mention is that I'm actually writing a KO1 right now, which is adapting one of our interventions for fathers and culturally adapting it for fathers in San Diego to use a soccer-based approach. So I've partnered with Grassroots Soccer, who they themselves have actually partnered with San Diego FC, the professional men's soccer team here in San Diego, to adapt the intervention. And I'm hoping to be a part of that work and see how we can reach fathers here locally as well.
That's super cool. Um, that's you answered my question perfectly. So just as a correlate, I take care of a lot of families here at UCSD with HIV, and in some of our Haitian families where I don't know that it's legal to be have multiple wives, but certainly culturally it is, and so it has been interesting to observe at least some of the families where we hear that the father, if he's negative, might spend less time with the HIV negative, I mean, with the HIV positive mother, especially if she gets ill. Not that he abandons her, but just anyway, it's been interesting to observe. So it seems to um, confirm your findings.
Oh, that's great to hear that there's consistency in what you're seeing and in what we found. And Dr. Blanchard, I'm curious to hear, in those families, are families disclosing, are the women disclosing their HIV status or often keeping it a secret?
Both.
Okay.
It
Yeah.
both. It depends. It depends on. It just depends. So we always our MO is to try to have the woman disclose her status, but obviously, there's issues of safety, whether it's domestic violence or abandonment. Everything you addressed. So
Yeah.
um, it's often not a black and white issue.
Yeah, definitely. We also see 50-50 disclosure rates.
Yeah.
There was a comment from Dr. Dice, outstanding talk and work. Thank you for sharing. And he had a shout out for San Diego FC, Nottingham Forest, Bristol Rovers, and Alianza Lima. And then a comment from Aaron Wilcott, very interesting work. I'm familiar with Dr. Biederman's work in Baja California, Mexico, looking at engaging mothers to impact social change. But targeting fathers seemed fresh and novel. In patriarchal culture could yield very powerful results.
Yeah, absolutely. I hear this all the time where, it's funny because we often really focus on the maternal child health outcomes and the fathers are often sort of left on the sidelines, no pun intended for the soccer analogy, but whether it's because we're not engaging them or because they don't want to engage, there's definitely a gap there. And I think it's up to us to figure out what that gap is and how we can meet fathers where they're at and engage them meaningfully in a way that they actually want to engage in. And I think it'll make massive waves in this field.
Other comments, questions? Gigi, you still have your hand raised. I didn't know if you had another question.
I do not. Sorry, I'll take it down.
Okay, no worries. Maybe I do have one, maybe people, if there are other questions, but how is your work, at least in Africa, going to be affected by the UN AIDS issues?
Oh, could you elaborate on the UNAIDS issues?
Well, I mean, the cuts in funding, all that stuff. Is
Yeah.
that, how are things going there, or have you heard?
Yeah, definitely there are major challenges with funding, and then staffing, of course, maintaining staff. But I think it's something that all of us are feeling, in NIH, CDC, and in many different funding sectors. So it has not been easy, to be honest. Joining the faculty in this funding climate has been very challenging for me. So in the last 4 months, I've submitted 6 non-federal grants, so to foundations, private sources of funding, hoping that that work can continue a lot of the work that we're doing in Sub-Saharan Africa. Almost all of my funding comes from NIH through foreign subaward agreements. I mean, our work is conducted through foreign subaward agreements to Kenya, Botswana, and Uganda. Unfortunately, if any of you work in global health, you know that um, foreign subawards have been frozen for the last few months. So that means no renewals, and new competing grants have actually been paused until they figure out their new structure for foreign subawards. This has been very stressful as I had actually written an entire K to do in Sub-Saharan Africa based on our preliminary data to create a father-based intervention. I decided to switch gears recently, and I'm actually applying for this opportunity with my K to adapt our father intervention for local fathers in San Diego, which I think is something that is very important for my career to really plant seeds and ground myself here at UC San Diego, as I hope to stay here for my whole career. But it also is something that is affecting sort of my research identity in a way, as all of my research has been done in Sub-Saharan Africa to date, well, except for some projects here and there. But I think that it's something that I'm trying to navigate, and I know that all of us are trying to navigate in our own way. But that being said, there's more clarity coming out now about how the foreign subaward research will work through NIH, and actually things are looking up. And so I'm very optimistic about our opportunities to get more and more funding from NIH to continue this important work in Sub-Saharan Africa. So I actually think it's going to work out.
Well, nevertheless, we here in San Diego will be more than happy to support your work if you end up doing more work here. So as Gabe Wagner says, we are lucky to have you. Thanks for sharing your work and look forward to seeing more.
Thank you.
Yep. Any other final thoughts, comments before we close for today? Richard says, love your optimism.
It's all we can have. I actually have a question maybe for the group, if that's okay, Dr. Lee.
Sure. Yep, please.
So for my K, I'm actually hoping to reach first-time expectant fathers in San Diego. And based on my experience in Sub-Saharan Africa, which I don't know if that translates here, I'm thinking of recruiting first-time expectant fathers through pregnant women. So maybe going to antenatal care clinics, and if a pregnant woman presents and we can maybe recruit through her and ask if her male partner would be interested in being part of the co-design of an intervention specifically for first-time fathers. I'm hoping this intervention can improve father mental health, improve parenting readiness, and improve relationship quality in the first year of postpartum. I'm curious if anyone has advice on how I can best identify those clinics or identify sources of, a population that might need an intervention like this or want an intervention.
Michelle, I do. This is
Yep.
Gigi Blanchard. I do. In fact, one of our HIV OB social worker actually just transitioned to, she's going to be working in all of OB, not just HIV OB. So if you could send me just a quick email, J Blanchard, then I can connect you guys that way.
Thank you so much.
Well, thanks everyone for being here today. Thank you, Michelle, for a wonderful, wonderful talk. It's always great to hear some new information, and especially I think the mixed methods data. We don't always get enough, I think, qualitative research, and I think it always goes to show how important a mixed method approach is to really understanding what's going on. So thank you very much, and everyone have a great weekend, and we'll see you next week. Thank you.
Thank you, Dr. Lee. Thanks, everyone.
Thank you.